Now doctor, we came to the proper hematology laboratory values. What is PT? What is APTT? You need to know that there are two methods. You have a tissue factor which will stimulate the factor 7 to get activated, which is basically called extrinsic pathway. Then you have a factor 12 becoming 12A, 12A go and stimulate 11A, 11A will go and stimulate 9A like a Facebook referrals. You have got a cascadic mechanism. Then 9A in turn will make 10 become 10A, even factor 8 also it will convert 10 into 10A, and that 10 to 10A conversion is crucial joint. Why? Because factor 7 ultimate job is also to convert 10 to 10A, and all these intrinsic factors job is also to convert to 10 into 10A. Okay, doc? Then 10A and 5 together will convert the factor 2, which is called prothrombin, into thrombin. 2 into 5 is equal to 10. Easy to remember. Then thrombin in turn, what it will be doing? It will convert the factor 12 into 12 or 13. What is the number here? It should be 13. 13 into 13A. 13A will basically make fibrinogen to fibrin. When it converts, the fibrin clot to get cross stabilized. So that is the purpose. Now tell me doctor, what prolongs the PT? Factor 7. Factor 7 deficiency. What prolongs ABTD? 12, 11, 9, 8, any of them. What prolongs both PD and ABTD? 2, 5, 10, because that's called common pathway. If the common pathway is there, then both PT and ABTD, both of them get prolonged. Hai na? Why? Normally if factor 7 is there, 10 should get activated and PD should be normal. अगर 10 ही नहीं है तो factor 7 का मतलब ही चले जाएगा ना. So that is the reason 2, 5, 10 will affect both PD and ABTD. Now what will factor 13 deficiency will do? अगर factor 13 deficiency है तो neither PT is affected nor ABTD is affected, but what is happening to the patient? He is bleeding clinically. अगर factor 12 का deficiency है तो there is another speciality. Patient will not be bleeding. Why he will not be bleeding? अगर factor 12 नहीं है तो किसका कमी हो गया? You have a problem with only your factor 9A. You have got still factor 8 available to activate 10 to become 10A. So that is the reason the patient will not be clinically bleeding, but he will have a prolongation of APTT. So summarize doctor, factor 7 deficiency prolongs PD, 2, 5, 10 will prolong PD APTT with a clinical bleeding. Factor 12, 11, 9, 8 will prolong APTT, but factor 12 prolongs APTT without clinical bleeding, and factor 13 causes clinical bleeding with normal PD APTT. Okay na? This is the one which is tested. इसके लिए this should be taught in first year very clearly, but first year we have only 3 months time for physiology. In that 1 month gone for ragging, 1 month for pre-final preparation. What is left is 1 month to read book. That time we don't have time for reading where is PT, where is APTT, a sub kaiku. Factor 8 is hemophilia. Do you know that? Know that. Factor 9B, what is it? Factor 9 is hemophilia B. Bus, pass. Entrance is all about these small petty questions with clarity. So what is thrombin time SS? It measures the fibrinogen basically. In some people they have a congenital efibrinogenemia, hypofibrinogenemia. In those people there will be clinical bleeding with a prolonged thrombin time. Then bleeding time reflects platelet function. You have a PT, APTT, normal bleeding time 2 to 7 minutes, and PT, APTT is 25 to 40. And those who are receiving heparin will have prolonged APTT because factor 8 is the one, factor 10 is the one which got affected. And those who have vitamin K deficiency in the early stages, what are the vitamin K dependent factors, doctor? Quickly, like a parrot. 2, 7, 9, 10. Then 2 and 10 and 9 are part of APTT, no? Why it is not prolonged in vitamin K deficiency in the early stages? Because between 2, 7, 9, 10, 7 has the shortest half-life. वो जल्दी मर जाएगा अगर विटामिन K नहीं है तो. First to fall. And since 7 decides PT. Early vitamin K deficiency, early liver disease में what is affected? PT. Late liver disease, late vitamin K deficiency में both PT and also APTT is what need to be remembered. Then comes the disseminated intravascular coagulation. It's already you know that. Consumptive coagulopathy, the fibrinolytic system is rampantly activated because of the gram-negative sepsis. Patients are critically ill. They have, how many of you have seen a septic shock patient in AMC acute medical care? You have to see today only, because we have a dengue, hemorrhagic diathesis, and you will come across sepsis quite commonly in a lot of people, and bleeding diathesis is very common. How expert you become in your housemanship depends upon which epidemic is prevailing during the time of your AMC posting, basically, and you need to go and see the patient. Now what are the causes? Infection, obstetric complications. For example, you have delivered a baby, after that you fail to deliver the placenta completely. Retained placenta can lead to development of sepsis. Septic abortions, multiple complications in obstetrics can lead to development of DIC. Internal malignancies like lung, pancreas, prostate, GI tract, APML, especially in leukemias, M3 variety of the AML called APML, there is a consumptive coagulopathy. And there snake venom, especially rattlesnakes, can lead to initiation of a coagulation cascade and lead to development of DIC. Then whenever the patient has a coagulopathy, what is the differential diagnosis? It can be due to vitamin K deficiency or due to DIC or due to liver disease. But how will be the situation in liver disease? Liver disease, late liver disease will cause both PT, APTT prolongation, but TT, fibrinogen, platelets, they are not affected. Vitamin K deficiency में early stages में only PT is prolonged but APTT is still intact, and the TT, platelet count, everything is normal. All of them get affected in case of only TT prolonged, PT prolonged, APTT prolonged is equal to DIC, is what you have to fundamentally appreciate. Now doctor, there will be ecchymosis, GI bleeding, urinary tract bleeding. Then what did we say? Why there is a PT-APTT prolongation? The gram-negative septic toxins are stimulating the coagulation cascade, and initially what are forming are thrombi. Later on, when thrombi have eaten all clotting factors, there is no clotting factor available, bikari ban gaya blood, and that lead to development of bleeding diathesis. Now what is the challenge in this situation? Shall I treat the thrombotic tendency or shall I treat the bleeding diathesis by giving clotting factors and FFP? Most of the scenarios of DIC we need to give FFP and treat the bleeding tendency. But there are few exceptions where in spite of the DIC consumptive coagulopathy, you need to give heparin instead of FFP. When DIC and consumptive coagulopathy is due to snake envenomation, then you need to heparinize the patient, because there the clotting problem is more severe than the bleeding diathesis, is what I want to underscore to all of you. Similarly, when the DIC is because of an underlying internal malignancy like a prostatic malignancy, you need to treat the patient with heparin in DIC, is what need to be understood. So how do you diagnose? PT, ABDD, bleeding time, TT, everything is prolonged. FDP are elevated, fibrin degradation products, D-dimer is elevated, and fibrinogen and platelet count are typically diminished. So doctor, this is one table I leave to you in the literature. Practically our medicine class is last today, but we restart from Monday. That's a story. On the website homepage we have given the schedule, but that will be very fast track medicine, totally in about how many hours? 3 weeks. 3 5s are 15 days, 15 3s are 45 hours. We will finish entire medicine, starting once more from cardiology. Cardiology is finished on Monday, Tuesday. Neurology on Wednesday, Thursday. What you do is, our guys are basically preparing those who don't have internet, the DVDs of all our earlier discussion. Slow track may we have done medicine, no? Medicine is like Bhagavad Gita, any number of times you revise, still it is an enigma, right? You try to review our previous video, and when you come, your classmates are all entrance going guys, but time is money. So very short time they have. So we will be quickly reviewing only the key points. We will also have few MCQs revising. Then we will have 3 weeks medicine, 2 weeks surgery, 2 weeks gynacs. By the time you will also enter into what state? Encephalitic state of exam preparation. February, no, by January first week you will be shivering to move anywhere. Tiffin carrier will come to the room kind of a situation. Now you are in still smoldering epidemic. By the time you become acute epidemic. So by the time we will finish all those things, and then farewell you for your final exams. Once you finish final exams, come back, we will once more have wonderful evenings together. So that is the plan. So doctor, we will continue. Peripheral smear, what does it show? It shows cystocytes in case of DIC, even just like in TTP. FFPs, transfusions, cryoprecipitates, low dose of heparin need to be given, and sepsis need to be stabilized hemodynamically.